Hello, I'm Christina Larson, and I will be presenting on radiopaque lesions, which is chapter 18 in our oral pathology book. A few house rules today: please turn your cameras on and make sure to mute your microphone. If you have any questions, please type them into the chat box and they will be entertained at the end of the presentation during the Q&A session. On today's agenda, we'll be covering traumatic or inflammatory lesions, neoplasms and tumors, congenital or genetic disorders, other radiopaque entities. Then we'll cover some review questions and have our Q&A session. A little bit about me. I'm currently a senior dental hygiene student at Lake Washington Institute of Technology. My dental hygiene passion is mentorship and helping others grow their skills. My two truths and a lie are: I know where Adam Sandler lives, I can't snap, and I have been bitten by a black leopard. If you want to know which one is the lie, feel free to ask me after the presentation. Traumatic or inflammatory lesions. Focal sclerosing osteomyelitis, also known as condensing osteomyelitis, involves pulpal involvement in an isolated area due to inflammation or necrosis. This lesion is usually a reaction to trauma. When associated with a vital tooth, it is typically referred to as an idiopathic osteosclerosis. When you hear osteomyelitis, think inflammation in the bone. Mandibular molars are typically the regions involved, and the first molar is the most often affected. This typically affects both genders equally, but is common in those under 20. Focal indicates that the lesion is usually isolated to one area, typically the apex of the tooth. Patients can be asymptomatic, and the lesion is usually diagnosed upon examination of the radiographs. Radiographically, the lesion presents as a radiopaque area at the apex of the tooth and the surrounding area. These lesions produce a combination of dense bone and radiolucent patches that may be diffuse, so they will not always exhibit a completely focal, opaque appearance. Typically, this lesion presents as sclerotic bone without inflammation, but depending on the extent of the lesion, there may be varying degrees of lucency. The involved tooth will be treated with endodontics, extraction, or restoration. Sometimes no treatment will be rendered, but the prognosis of the tooth depends on involvement of necrosis or infection. The osteomyelitis may resolve once the stimulus is removed, or the sclerotic bone may be present indefinitely. In both cases, it is important to stress the importance of regular maintenance visits with your patient. Carefully document your radiographic findings and dialogue with your patient. Differential diagnosis includes periapical cemento-osseous dysplasia, cementoblastoma, osteoma, and complex odontoma. Osteomyelitis with diffuse lesions. Radiopaque lesions may have varying levels of density and can extend through each quadrant. Osteomyelitis can be focal or diffuse depending on the extent of the bony involvement. If large areas of bone are involved, it is technically diffuse. True osteomyelitis is normally caused by infection. Diffuse osteomyelitis usually occurs in the angle of the mandible and can extend throughout the infected quadrant. Chronic osteomyelitis may include a wider area, and the associated bacteria may be more infectious. This sometimes involves long-term, low-grade inflammatory response. Neoplasms and tumors. A neoplasm is an unregulated growth of tissue due to genetic change or mutation and can be classified as benign or malignant. A tumor is a raised lesion without fluid greater than 2 centimeters in diameter. Neoplasms may have varied appearance depending on their stage of development. Cementoblastoma, also called a true cementoma and a true tumor of cementum, is a benign odontogenic tumor. It is characterized by proliferating cementum-like tissue. Cementoblastomas usually present in those under 21 with no gender predilection. Although rare, there are reports of cementoblastomas in children under 8. The most common site of occurrence is the posterior mandibular region, with first molars most commonly affected. When multiple teeth are involved, the maxilla is more common. The lesion is a neoplasm of cementoblast and is considered the only true neoplasm of odontogenic origin. The lesions may produce pain, and the tooth remains vital. The cementoblastoma is attached to the tooth root and appears radiographically as an opaque, calcified mass and typically has a radiolucent border. Although pulp tissue may be vital, because of the disruption of normal neural nerve impulse transmission, the tooth will not test vital with an electric pulp tester. On radiographs, it will appear as a calcified mass with a radiolucent halo on the outer perimeter, which is the periodontal ligament space. This lesion usually presents with swelling. Your patient may present with pain as the only symptom, so the clinician will need to categorize the characteristics of the lesion, including stage of development and vitality of the tooth. Typical treatment is extraction because of the unlimited growth potential, even though the tooth is vital. Differential diagnosis includes focal sclerosing osteomyelitis, hypercementosis, or odontoma. Odontomas are mixed odontogenic tumors comprised of both epithelial and mesenchymal tissues. They are the most commonly occurring odontogenic tumor. Odontomas are developmental anomalies, and the tissue involved is a mixture of enamel, dentin, cementum, and pulp. They are believed to be a disturbance in the tooth development and may be found with odontogenic cysts and other tumors. There is also a hereditary component. Those under 20 are most commonly affected with no sex predilection. Odontomas are a mixture of both epithelial and mesenchymal dental hard tissues. Odontomas are usually asymptomatic and discovered on routine radiographs. Two types exist: compound odontoma and complex odontoma. Some odontomas may show features with both complex and compound varieties, but regardless will appear with a radiolucent rim, which is the follicle in which they develop. The compound odontoma resembles a collection of small teeth. Compound odontoma is usually found in the anterior maxilla and may be evident when normal eruption patterns do not occur and permanent teeth may be blocked from erupting. This is especially noticeable when failure to erupt is unilateral and can cause facial asymmetry. The complex odontoma consists of a collection of hard tissue and includes deposits of enamel, dentin, cementum, and pulp in a mass-like calcified form. Complex odontomas are usually found in the posterior mandibular region. Complex odontomas appear radiographically with less definite form or shape compared to compound odontomas. Osteomas are of unknown origin, but trauma, infections, and developmental defects have been suggested as possible causes. They occur in the 2nd to 5th decade of life, and males are more commonly affected. The growths may occur in the maxilla and mandible, the skull, and the sinuses. The bony growths may be in the condyle, mandible, maxilla, or even in the sinus region. The osteoma is a benign tumor consisting of mature, compact, or cortical bone. They may be classified as periosteal, occurring on the surfaces of bone, or endosteal, occurring in the bone. Osteomas are slow-growing but may eventually reach larger sizes, causing expansion and deformity. The patient may notice facial asymmetry. Depending on its size, some subtle swelling may be noticed extraorally. The patient may experience headaches, sinusitis, or vague related symptoms. They may also be entirely asymptomatic. Radiographically, osteomas appear as a dense, opaque growth on the bone. Osteomas usually exhibit sharply defined radiopaque structure with clumped calcifications that resemble tooth-like structures. Sometimes, a radiolucent rim is seen on the periphery of the lesion. Differential diagnosis includes exostosis, cementoblastoma, odontoma, or focal sclerosing osteomyelitis. Gardner syndrome, also known as familial colorectal polyposis, is inherited as an autosomal dominant disorder characterized by polyposis coli associated with multiple hard and soft tissue tumors. It is caused by mutations of the APC gene. Gardner syndrome manifests osteomas of the bones and sometimes odontomas, epidermoid cysts, supernumerary teeth, and other benign tumors of the skin and soft tissues, gastrointestinal polyps, and multiple polyps. If left untreated, the associated polyps usually develop into malignant invasive adenocarcinoma in the gastrointestinal tract and the stomach by the 4th decade of life. Gardner syndrome is the most common form of the hereditary polyposis syndromes. Although osteomas and odontomas can present in the mandible and maxilla, the mandible is the favored location. The facial bones develop osteomas, leading to facial asymmetry. Clinicians should be aware that the osteoma is the hallmark of Gardner syndrome. Early treatment is crucial since there is a fatal outcome of malignancy in relation to the polyps that accompany the syndrome. The polyps have a 100% risk of undergoing malignant transformation. Family members should be advised to have screening since it is a variant of familial adenomatosis polyposis. Dental clinicians can play a crucial role in the recognition of Gardner syndrome. Osteomas may produce few to no symptoms, and they may only be discovered during a dental visit. Providing early treatment is important to the prognosis of the disease for both the patient and their family members. Congenital or genetic disorders related to radiopaque lesions are sometimes not diagnosed until the clinician takes a radiograph or the patient exhibits a symptom indicating a problem. Osteopetrosis is also known as Albers-Schönberg disease and marble bone disease. It is a congenital sclerosing disease of bone characterized by osteoclastic dysfunction. Several types of osteopetrosis are possible in this group of genetic bone disorders: autosomal recessive, intermediate autosomal recessive, and autosomal dominant. This disease has a hereditary component. The age of the individual will vary with the type of osteopetrosis diagnosed. The autosomal recessive form may be evident in infants and has a fatal outcome within several years. The intermediate autosomal recessive form may become obvious in the first decade of life and is very aggressive. The benign autosomal dominant form may become apparent as increasing bone disturbances occur in midlife. Osteopetrosis occurs equally in males and females, and its development occurs almost exclusively in the mandible. The level of bone involvement varies, but the disorder is characterized by a noted increase in the density of the bone. Prognathic profiles are a clinical sign of osteopetrosis. Radiographically, there is skeletal density with an amorphous aspect, narrow space encroachment, and malformed teeth that may appear clinically as an odontoma. Clinically, there is delayed tooth eruption, enamel hypoplasia, and thickened lamina dura. Although the bones appear dense, they are of poor quality and break easily with pressure. Bone fracture and osteomyelitis are often experienced by the patient. Often, osteopetrosis is diagnosed when these events occur. Antibiotics, hematopoietic stem cell transplant, and hyperbaric oxygen can be used as treatment depending on the case. Prophylaxis with fluoride is recommended. The patient is at risk for multiple bone fractures during extraction if the disease is not recognized. Patients with any form of osteopetrosis should be seen in a dental school setting for a multidisciplinary approach for adequate care. Differential diagnosis includes Paget's disease, hyperparathyroidism, acromegaly, and malignant bone disease. Other radiopaque entities. Another entity that should be discussed is the calcification that is sometimes witnessed on a panorex in the carotid and lymph node locations. They may be asymptomatic and may not even be palpable. The carotid calcification can cause significant vascular occlusion leading to a stroke. Calcified lymph nodes are typically evidence of past infection with multiple recurrences eventually producing fibrosis within the node that subsequently calcifies. Additional radiographic surveys may be needed to determine that the calcifications are in the lymph nodes and not the carotid artery, which would be a serious medical problem. Any noted calcification should be reported to the patient and referred to their primary physician. Differential diagnosis can include calcified lymph nodes, phleboliths, submandibular salivary gland sialoliths, and tonsilloliths. Question 1. What normally causes true osteomyelitis? True osteomyelitis is usually caused by infection. Question 2. What determines whether an osteomyelitis is focal or diffuse? This depends on the level of bony involvement. If there are large areas of bone involved, it is technically diffuse. Question 3. What is the only true neoplasm of odontogenic origin? Cementoblastomas, which comprise 1% to 6.2% of all odontogenic tumors. Question 4. What is the most commonly occurring odontogenic tumor? Odontomas are the most commonly occurring odontogenic tumor. Question 5. What are the two types of odontomas? Compound odontomas and complex odontomas. Some may show features of both. Question 6. What are the two classifications of osteomas? Periosteal, occurring on the surfaces of bone, or endosteal, occurring in the bone. Question 7. What is the hallmark of Gardner syndrome? Osteomas are the hallmark of Gardner syndrome. Question 8. What is the risk of polyps in Gardner syndrome undergoing malignant transformation? The polyps have a 100% risk of undergoing malignant transformation. Question 9. What kind of profile can be a clinical sign of osteopetrosis? A prognathic profile is often a clinical sign of osteopetrosis due to the dense, generalized sclerosis of the mandible. And question 10. What is the reason for additional radiographic surveys when a calcification is observed in the lymph node area on a panorex? To ensure that the calcification is not located in the carotid artery, which would be a serious medical problem. And now it is time for questions and answers. I see we have no questions in the chat. So that concludes my presentation. You will receive your CE certificate, which looks like the image on your screen, to the email you registered with. Thank you for attending my presentation on radiopaque lesions. My email is on the screen. If you have any additional questions, feel free to reach out to me. Thank you.